This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Stacey Clardy from the Salt Lake City VA and the University of Utah. Today I'm speaking with Geoff Ling. Geoff is a neurologist at Johns Hopkins, but prior to this current role, he was for years the only neurointensive care specialist in the U.S. military, retiring as a colonel, and next going on to serve as the founding director of the DARPA Biological Technologies Office from 2014 to 2016. DARPA, of course, standing for Defense Advanced Research Projects Agency. Geoff, we have wanted to have you on the Neurology podcast for years to talk about TBI. And then I was recently perusing the news media and I came across an article, totally unrelated, published in the New York Times on November 6th by Matthew Callahan. The title of that article is A Secret War, Strange New Wounds, and Silence from the Pentagon. Now, to be clear, you were in no way involved with that article, but when I read it, I immediately thought of your expertise, especially from your time in the military and with DARPA. And I'm so glad you could join us today to try and unpack some of that article, shed some light on what we need to know as neurology clinicians, most of us civilian, without military or combat experience, about the unique types of head injuries that our active duty military are suffering. And I think this becomes especially relevant with more and more military members because once retired, many are being seen in the community. I work at a Veterans Affairs hospital in a fairly rural area of the country, and many veterans just can't make the drive easily to our center. And so the community neurologists seeing these veterans don't really even have access to their service records and exposure history to help provide context either. So I'm hoping that you'll be able to give us some guidance there as we get talking. Now, first, for context, that New York Times article focused on a particular group of military service members, specifically the units who fired tens of thousands of high explosive shells. And I'll cite the article here, quote, "The cannon blasts were strong enough to hurl a 100-pound round 15 miles, and each unleashed a shockwave that shot through the crew members' bodies, vibrating bone, punching lungs and hearts, and whipping at cruise missile speeds through the most delicate organ of all, the brain," end quote. And I would step back and I'd encourage everyone to take a peek at videos of rapid fire mortar shooting. You can find these easily on the internet. And take a look at the positioning of the soldiers in those videos. I think it's fair to say you'll see it's like standing next to a tank barrel, essentially, with your head 1 to 3 feet from the end of the barrel and firing hundreds of rounds. So really inconceivable that this wouldn't have some impact on the brain, but it's obviously a very important type of munition, and the solution is not so simple as to say, well, just don't use it. So with that background, the article questions if these artillery battalion members suffered a novel form of a traumatic brain injury and were perhaps left with resultant chronic traumatic encephalopathy, CTE, but outside of the more commonly recognized ways we think of individuals acquiring CTE, such as through many years of high-level professional football or otherwise through traumatic blast injuries in the military. And we won't go into a full primer on CTE today, but if anyone wants background, we've covered this a lot on the podcast in the past about traditional CTE, including the October 2nd, 2023 discussion with Alec Menzie interviewing Marianne Shanti Ketterall about the association between TBI and cognitive decline in older veteran men. Then again, the May 26, 2022 episode with Shuva Roy interviewing Anne McKee on CTE and TBI in football players. And then we also have a great comprehensive delayed recall in February 2020, entirely devoted to CTE and head trauma. And we've actually even covered some of these potentially less common causes of head injury before. One that specifically comes to mind is an interview where Jason Krause spoke with Matthew Futterman about his New York Times article on neurologic sequela in sledding athletes, right? So bobsled, skeleton. And that was on the October 19th, 2020 episode. So that was a lot of background, but I wanted to make sure to sort of frame this correctly. And so maybe we start there, Geoff. Do you think that CTE is at all a plausible theory to explain what has happened to these artillery battalion members?
So thanks very much, Stacey. You are correct that this is an evolving story. And so I want to unpack this a little bit. So CTE, or chronic traumatic encephalopathy, is a pathological finding, much like tauopathies are, much like many of the other neuropathological findings that we often find in brain at postmortem. And the question then is, what are they related to symptomatically for those of us who practice neurology in the context of what the neuropathologists find at the autopsy? So CTE itself is a neuropathological finding. Is it, in fact, associated with, as you're asking, blast-related traumatic brain injury? Or if you were in another setting, perhaps associated with professional sports and the like, that is work that's evolving right now. So we want to make sure that we don't ascribe a mechanism yet to what we're still trying to understand. So let's start with TBI itself and blast TBI, because that's really what the question is here. And this is distinct from our classic head impact TBI, such as you get from a motor vehicle accident or you get from contact sports and the like. This is different. This is where the obvious cause of the TBI is not a direct thing like an object. And it really is a consequence of a shock wave. So I want to go back a little bit in time here. So when the war initially broke out back in 2001, we're talking about the global war on terror in Afghanistan and Iraq, we, as in the world of neurology, understood concussion, and we, in the world of neurology, understood that it was related to mild traumatic brain injury, TBI. But that was not universal, as you know. Back in 2001, many remember playing on the soccer pitches or playing football or playing baseball or basketball. And when you get hit in the head, the coach may pull you aside, tell you to shake it off, may look at you, tell you, do you recognize him? And you say yes, and then go get back in the game. It'd be tough. We've come a long way since 2001. But 2001 is when the global war on terror first started, and where the military started taking notice that traumatic brain injury, concussion, was more than just shake it off and get back in the game. So in 2001, you did not find concussion care centers. In 2001, you did not find protocols for managing concussion. You had the American Academy of Neurology's position statement on concussion, and that was probably the most valuable thing that was out there for mild head injury. The AAAS, the American Association of Neurological Surgeons, of course, had their management guidelines for severe traumatic brain injury, but that's out of the scope of what we're talking about right now. We're talking about concussion, really. So that's what we started from back then. And this is when Ann McKee and her folks up at the Boston VA and Boston University were actually starting to do their exploratory studies, looking for neuropathological evidence of some of these things that we were finding. So a lot of things were happening just in the last 20 years. So as time evolved, and I'll share with you some of my personal experiences. In 2003, when I first got deployed, that was the first time I went to the war theater as a practicing physician, and I went as a neurointensivist. So I was deployed to the 452nd Combat Support Hospital in Afghanistan in 2003, and already then we were starting to see evidence that there was concussion that was unrelated to just being hit on the head, but rather being exposed to a blast wave. And what we found were that there were already soldiers that were already being exposed to IEDs, improvised explosive devices, homemade bombs. And so these bombs, when they went off, yes, of course, if you're caught in the blast radius of the bomb with the shrapnels flying around and the heat wave and all that, you're getting obvious injuries that were very noticeable. However, there were those soldiers who were not exposed to the flying shrapnel, seemingly way out of the range of what one would expect from getting hit or thrown through the air, but rather the shock wave itself. So you can imagine that if you were 5 feet from the bomb, of course, you may have lost an arm, you may have gotten a severe laceration, this sort of stuff. But if you're 20 feet away, you would say, why is this person hurt? And why are they having headaches? Why are they having cognitive changes? And we realize that there must be something from that blast wave, just temporarily when it started, to being exposed to the blast wave. And initially the thought was, is this a form of PTS, post-traumatic stress disorder? And very quickly it found out that the clinical presentation of PTS was dramatically different than what we're finding with the concussion patients. So already we knew that there was a separation there, but that took a little bit of time to elucidate. But at 2003, already the Defense and Veterans Brain Injury Center, the DVBIC, which was set up right after the Vietnam War for studying traumatic brain injury by the Department of Defense and the Veterans Administration, I might add. So remember, it's the DV, Defense and Veterans Brain Study. And so they've done these longitudinal studies looking for a long time since Vietnam, and actually had an indication that probably the blast waves were coming about. But there was a big difference between Vietnam and, of course, the global war on terror, and that is body armor. So when I deployed downrange, they issued me body armor. This body armor is pretty good, let me tell you. It will stop a lot of shrapnel. It'll stop a pistol bullet from point-blank range. This is really good body armor. And it'll actually with plates defeat rifle rounds. So we were protecting the body, but we weren't protecting the head. We had the old-fashioned helmet, of course, but we didn't have the same level of protection. What was happening was the soldiers exposed to blast with all the shrapnel flying around and things were actually surviving it because of the body armor. But now we're starting to see that Perhaps in Vietnam, if they had not died, we would have picked up this TBI earlier. But the fact that they had a severe abdominal injury or chest injury, something, and subsequently expired, you didn't have the opportunity to see that they may have had a concussion. So in this situation, now that we're protected, we have concussions. And these are starting to come about. And that's when we started realizing, oh my goodness, to your point, Stacey, is it something more than meets the eye here? And of course, it comes down to the pressure wave. And that's what we're talking about. That's the link between the TBI that was coming about from the global war on terror, Afghanistan and Iraq, and today's New York Times article talking about shockwaves coming from the weapon systems being used by our soldiers. In other words, is this self-inflicted?
So this is a great clarification, and part of what I'm hearing you say is language really matters at this stage of discovery. It's really not fair at all to lump all of these TBIs and perhaps subsequent CTE together. And following on what you said, I did find a paper linked from that New York Times article. It was a postmortem pathological research study of brain blast injury, right? And it was published in Lancet Neurology back in 2016 by Daniel Pearl and colleagues. And Daniel is a neuropathologist who runs a Defense Department tissue bank that preserves veterans' brains for research. That paper was titled Characterization of Interface Astroglial Scarring in the Human Brain After Blast Exposure, a postmortem case series. Now, it's been a few years, but they showed then that chronic blast exposure cases, so as you say, the shockwave, showed prominent astroglial scarring that involved the subpial glial plate, the penetrating cortical blood vessels, the gray-white matter junctions, and the structures lining the ventricles. Now, that paper was 2016, but I think what I hear you saying is this pathological difference is holding up, and we're expanding on that. Is that right?
Yes, that's right. I know Dan Pearl personally. He's a phenomenal neuropathologist. He is at the Uniformed Services University of Health Sciences, which is the military medical school in the Department of Pathology. Dan's work is really seminal work because he's showing clear relationship between a lifetime of service and these neuropathological findings. That is a correlation, Stacey. That's a correlation. You would then say during their lifetime of service, were they exposed to blast shock waves from a number of different things, including IEDs and also weapon systems? And the answer is there's a good reason to suspect that there is a cause and effect. Is there a smoking gun yet? The answer is no. But there's enough evidence from Dan's work and Ann's work, by the way, Ann McKee's work, another member of the American Academy of Neurology, to show that this is to be concerned about. And what do you do about it, Stacey? Right? I mean, you can wait for all the research to be done, or you can act. And so the point here is relevant to practicing clinicians. What do we do? What do we do? Right? So I bring you back to the story that I was coming up with before, which is in the military, we had the same question back in 2005. So in 2005, I was deployed again, this time to the 10th and the 86th Combat Support Hospitals. I deployed to 2 different hospitals during my time there. And that was to Baghdad, Iraq. And that was really when there was a big shooting war. And we saw lots and lots of patients, lots and lots of trauma, the whole 9 yards. And when we came home from that, we recognized there is no question that we're seeing dramatically higher incidences of mild traumatic brain injury / concussion. And it wasn't because of getting hit over the head with a rock, but rather it was being exposed to IEDs. The question then became what in the IED was causing that problem? That's the key question. Because when you see an IED go off, as you pointed out, they can look at videos of it, you see a big flash. That's a lot of light. Then there's a heat wave. Then there's all the shrapnel that goes flying around. And then there's a bunch of other stuff. But most important is the pressure wave. They're trying to take down buildings and hollow structures like tanks. All right. And so what happens is they optimize the shock wave. And so if you actually look at a shock wave called the Freelander plot, you'll see that there's a huge spike in pressure. We call it overpressure. Then it drops down, and then there's a negative pressure wave. That push-pull becomes very important to the brain. Very important to the brain. In 2008 at DARPA, we launched a program called Preventive Violent Explosive Neurotrauma. And it was to explore just this. This is 2008. And it looked at it from a preclinical and a clinical standpoint. And to summarize it quickly, we found that in the preclinical model, we saw many of the same things that Dr. Pearl then described in 2016. So the clinical models were appropriate. You saw the same neuropathological changes. You saw changes in certain brain markers, the S100 beta, the aquaporin 4. These were all increased. The myelin basic protein, it was increased. Neurofibrillary protein, the heavy chain, was increased. The NFH was increased. All of these things are consistent with what we see clinically now. And so we know that shockwave does cause an acute brain pathology. But our brains do recover, Stacey. Our brains recover. The question is, all of us have suffered a concussion at some point, but we're all not brain addled. So how much is too much? That's an important question to ask, is it not? At what point does it become a point of no return? In other words, you get such a burden of the same changes that Dan saw on his specimens and Ann is seeing that you ultimately give rise to CTE long term. And we would all agree that it's a burden. What is the burden of the insult? You may get hit once or twice and be fine. If you get hit 1,000 times, such as in the New York Times article, that may be, in fact, way too much. And then you would ask me, what about the weapon systems? Was it elucidating the weapon systems? And part of that study was a breacher study. And these are Marines who are taught to blow open doors and windows, much like police officers do. But unlike police officers who blow open doors and windows to gain entry into a building, the Marines use much larger charges for obvious reasons. And they expose themselves to these blast waves. And so you ask yourself, gee, has anybody studied them? The answer is yes, they have. They put blast gauges on them, pressure wave gauges, so they could ascertain what was the burden of shock wave. And we found a number of very interesting things, that the shockwave absolutely was related to certain clinical conditions, some reversible cognitive conditions, high-level processing, the ability to concentrate. Sleep was affected. The other thing, of course, was, what was the clinical presentation? Headaches. And so that became really important, because what happened at that point was we established a clinical care concussion program in theater, in the war theater. In 2009, the U.S. military instituted combat concussion care centers located throughout the forward operating bases. And what it was is that every soldier that was thought to have been exposed to a shock wave, or perhaps even got thrown through the air, or got hit on the head in barracks goofing around, they had to go to the combat concussion care centers and be evaluated. That's super important. You've got to diagnose to know. And so we started to put those in place. And I'll point out that the military is very serious about it, because we wrote something called the DTM 09-033. You can look this up. DTM stands for Directive Type Memorandum. And that is a general order that goes throughout the entire military. It was signed by the Secretary of Defense himself. And what it did was it mandated screening. So this is super important. When our clinicians see a patient where they're concerned about exactly what we're talking about, first things first, you have to do a detailed neurological examination, much like this was mandated, before you can send them out of the clinic. That's number one. How do you do that? Well, if it's acute, go ahead and use the SCAT, which is the Sports Concussion Assessment Tool. They're at the 5th version now. It's published. It's in the British Medical Journal, but you can actually look it up. That's a good way to start. It looks at all the things that should be looked at. It's just not cognitive things. It is balance. It is looking for nystagmus, for example, looking at hearing, all these things that neurologists take as part of their routine examination. It helps them quantify it in a format that becomes usable to other clinical specialties such as physiatry or neurosurgery, who may also get involved. But the first things first, the clinicians have to do this. We all have to do this. And this should have been done on these Marines, by the way, and I expectations that they did do that. The second thing is then what do you do? What do you do? Well, the VA and the DOD got together back in 2009 and developed the first clinical practice guidelines for management of mild traumatic brain injury concussion, especially that which is related to blast exposure. You spoke of clinicians who are in the rural areas. They can take advantage of the fact that the VA has published these clinical practice guidelines, and actually there's a newer version of it. And is, how do you manage a patient that you believe may have been exposed to a blast-related injury or suffered long-term consequences therein? The VA published these clinical practice guidelines. I'm happy to say that in 2009 we started doing this. And it's based on evidence-based approaches, using the same approach that we use for any kind of evidence-based guidelines, that the VA took a leadership with the DOD to put these things out. And it's meant for all clinicians. This is not some sort of military secret or anything. These are all based on the clinical findings.
And this is important, especially chronically. So maybe once you're out of theater, you're back home, because it can be common to mistake a blast injury in the brain for something else if you don't know this history, right? Because when you walk into clinic, it can look like a lot of things. Is that fair?
That is absolutely fair. You can imagine a professional sports athlete, for example, suffering some of these things. I think of Steve Young, for example, from the San Francisco 49ers, who's been public about his experiences having multiple concussions. It will look a lot like that. It will look like that. Classic presentations.
Like sleeplessness, depression, anxiety, other symptoms. And sometimes when docs hear this in the community and you say, oh, by the way, I'm a veteran, they might be tempted to label this PTSD. But would you say it's important to differentiate?
It's absolutely important to differentiate, Stacey. Our psychiatric colleagues are very good at their diseases. We neurologists are good at our diseases. And a neurologist really should not be managing psychiatric disease, nor should a psychiatrist be managing neurologic diseases, right? So, and I put brain injury, since we're brain doctors, in the category of neurologic disorders. And those patients who are suffering significantly from those elements of a traumatic brain injury should have a neurologist, in my personal opinion, as their primary. Now, we will use our psychiatric colleagues to help us manage other elements of it, such as the anxiety and the like. But the overwhelming presentation of many of these patients, we focus on the anxiety and the depression in the newspapers they do, but we as neurologists know that one of the most debilitating things is probably going to be the headache, the lack of the ability to concentrate, and the loss of executive function. Those are things that are in the neurobehavior standpoint that is really within the bailiwick of the neurologist. And that's why, and it's associated with clear neuropathological findings. And that's why I come back to the CPGs. How do I manage this when I don't manage many of these? Is that fall back on your clinical resources. And the VA, if you look at the clinical practice guidelines page, you can download for free, absolutely for free, the clinical practice guidelines, and that will help the ability to manage these patients. But you're correct. You have to identify them first. But always ask the question. We all learned in medical school and when we're first-year students and taking our first class in H&P, history, history, history.
So where does this leave us? Coming back to when you were talking about explosion and the overpressure, I mean, can we get troops even a bit further away from the blast? It would be a massive improvement, right? Like you alluded to this, but the explosion overpressure wave declines with the cube root of the distance from the explosion. So a person 3 meters from an explosion experiences 9 times more pressure than a person just a little bit further away. So even if we could get the heads of those soldiers 1 meter further away from the mortar round, it would be dramatic.
Well, there's many things that we can do, Stacey, but standing further away does help. But you got to stand further away in the right setting. What you spoke of is what we call free field. There's nothing around you. You're in the middle of an open field. You got your cannon, you're blasting it off. Stand a little bit further away, and the shock wave dissipates very quickly the further you stand away. And that's absolutely true. But if you're standing next to a wall, for example, which a lot of soldiers like to be, because if you're in a gunfight, you sure like to have a piece of concrete in between you and the other guy's rifle. Therein lies a problem. Why? Because these shock waves can bounce off of walls. If you're in a corner, you can actually get a magnified shock wave. So where you stand and how you stand is important. Why did I say that? Because another form of artillery is called a mortar. And a mortar is a tube where you drop the round in and it fires off. And you often stand in a pit. You stand inside of a hole you've dug and you put your mortar up. But when that shockwave happens, it reverberates around the walls of the little hole you're standing in. You follow? So it's not a matter of just standing further away. It's how you stand away. So that's one thing we should do. And we should collect data to know exactly how much you should stand away. That's very, very important. The Breacher study showed that if you were the first man in the stack, you were actually more protected than the second guy. Why? Because you were under the blast blanket when they fired off the round. So where you stand is important, but it should be data-driven, Stacey. And I think what's happened here, and this is really a mistake. So now we have the new young soldiers and Marines and airmen and seamen out there, and I'm wondering if they're wearing blast gauges. If they're not, why aren't they? That's a question we should ask. We got to collect data, and then you want to get them further away. If they're firing a Gustav anti-tank weapon, for example, yes, you're correct. The loader used to stick the rocket in the back of the tube and kind of hunch over, right? We've seen that all in the old World War II movies. But the point is that guy should get out of the way, because that back blast of that weapon, in fact, exposes them, less so of the operator, right? So these are things that we find out as we collect data, which is, I think, is the reiterating your point, is the obvious thing to do is, can we stand a little bit further away? The second thing is, can we develop a better helmet? A helmet that can dissipate some of the shock wave before it actually crosses the skull through the cranial vault. These are questions and opportunities for the future. And we as clinicians, wouldn't it be lovely, Stacey? You're a VA doc. Wouldn't it be great if you just went on the EMR, electronic medical record, and upflashed the service record, and it showed what the lifetime exposure to blast the patient sitting before you had, because that data would then be available. This is the kind of data that we clinicians could use to best manage our patients.
Right. Now you can sort of get an idea by interviewing your veteran and finding out what theaters they were in, but yeah, that's never going to be really quantitative in that fashion. And I could ask you questions all day long about how do you decide what to shield and things like that. But what do you say when you have a veteran in front of you in clinic who is clearly struggling from this, and you know exactly what they were exposed to? You know, maybe they even have their loved one with them. How are you counseling them? What are you telling them to do on their day to day? What are some pearls for us there?
So there's a few things. Number one is that this, in fact, is a treatable condition. It is not necessarily a curable condition, but we're neurologists. There are many things that we treat and we can manage, but we do not cure. Epilepsy is classic. All right. So in this situation, number one is I try to find out, again, with the history, what is your chief complaint? What is your chief complaint? Many times when you ask that simple question, they'll say, well, what's really bothering me, doc, is I'm seeing double vision. I'm getting a little bit of diplopia and these things. And that is, in fact, leading to my headaches. Well, that's really good because that shockwave affects the eyes as well as does the brain, does it not? So here's where getting the optometrist to take a look at his eyes may, in fact, be very helpful because we found in theater that about 25% of the patients who came to us with acute concussion from blast, in fact, were complaining of vision issues that were anterior to the brain. So this is a situation where that's an easy fix, is it not? The two biggest complaints you will get, though, without a doubt, is headaches. And the second, of course, is sleep disturbance. And sleep disturbance is no little thing. We all know that. Herein is where we can actually have an impact. If we can manage their sleep, manage their headaches, you can find that you can take care of a lot of the issues that a lot of these patients are having. Then after that become things like executive functioning, thinking, processing, and that sort of thing. But again, first things first, let's drill down on it. We started this by saying not every single one of these patients is the same. And that is in fact true. Just like every epilepsy patient, every headache patient that we have in our clinics are not the same. First things first, what of the constellation of clinical symptoms that they could have are they having and what bothers them most, and then start to drill down at them one at a time and start to manage it. But I tell these patients that we may not be able to cure you, but we can manage you and we can help you get through this. And the most important thing is that they're not in theater anymore. They're not getting exposed by blast anymore. So what was, and what we can do now is manage what is today.
Right, that's great advice. And often I will tell you the first thing I say when they come to their first VA neurology appointment is, look, you're not an asset, so I'm not just going to give you ibuprofen. We're going to sit here and we're going to really drill down and treat this. But I will say too, practicing in the VA, we have access to headache treatments that I don't have across the street for civilians. And certainly I think I hear you hinting at this too. Maybe start with the sleep study. Let's characterize how much of this is PTSD, how much is sleep initiation from anxiety or other things, and sleep apnea, right? And that all feeds into the brain fog too. So really, is it fair to summarize and say you're going back to the basics, like get each symptom, dissect each symptom, understand it, treat it as such? Is that what I'm hearing?
This is the best thing about being a neurologist, right? I love being a neurologist because we still do things that other specialties seem to be abandoning, which is we actually talk to our patients and we examine them. Do you know any other specialty that examines a patient the way we do? And that is where you have to start, because when you listen to them and you examine them, you find things, right? And that is absolutely the most important thing we could do to manage these folks, because once we can elucidate what in fact are the primary things that are bothering them, we can actually address them. Now I'm going to come back a little bit more. It's just not blast TBS. So our civilian counterparts don't see as much of this for the obvious reasons that you articulated. But let me tell you, if they have somebody who's been playing football or basketball or another contact sports for a long, long period of time, they're going to see the same thing. You're going to see the same thing. I'm sure you're going to see the same thing. And they have to learn how to manage it, because before 2001, before the war, we all know how TBI was treated. The plethora of concussion care centers came after all these problems were elucidated first in the veteran population. And only secondarily was it being adopted by everybody else to realize that, oh my goodness gracious, here we have a problem here, that concussion is not a benign injury and that concussion can have long-term consequences, and that we all in the medical community should be managing it. But here's where neurology can take leadership, because again, this is a brain injury and it can be very subtle. Now, by the way, there is a difference between PTS and these brain injuries. However, they can come together. So in the veteran population, imagine that you were, and I saw this a lot, you were in a blast field. Bam, there it goes. Yes, I'm addled now. I'm staggering around, but I wasn't hit by shrapnel or anything, but I have suffered a concussion. But at the same time, what am I doing? I'm looking at two of my buddies who have their arms and legs blown off, and I'm 18 years old. And I was eating lunch with them just about an hour ago. And now they're screaming. Maybe two of them are dead. Of course you're going to have mental health issues. Of course you are. So we have to manage both. And in fact, we learned quickly that we had to put the combat stress teams, co-locate them with the concussion care centers. Because unless you've been to war, there's nothing quite war is a horrible thing, Stacey. It's just truly a horrible thing. But you know what? It happens, right? And sometimes it's foisted on you, and sometimes you have to do it. And we send young people to do it. Stopping the Nazis, that was worthy. So we send young people to do it. And these are the kind of things they face. So it is not ever in isolation. Do not be surprised if your concussed patient from the war also has some PTS issues. And you say, well, how do I know that they have PTS and not also an overlying concussion? Flipping the question, right? PTS is associated with flashbacks. The predominant, not all, but many are associated with flashbacks. There's none of the blast injury patients, pure blast injury patients, have been shown to be flashbacks and the other elements of PTS. So we in neurology should get comfortable, especially if you work in the VA, of what the diagnosis of PTS is. Because there are elements in there, and this, by the way, some of this work has been published in the New England Journal of Medicine as well. The differentiation between PTS clinically from mild traumatic brain injury is very clear. There are certain things associated with PTS and certain things associated with TBI, and they don't cross over. And so it allows you to understand that, oh my gosh, sir or ma'am, I understand that your chief complaint is X. If it's flashbacks, yes, they could have suffered a concussion, but their primary problem, and the thing they're worried most about, of course, is their psychiatric disease, and they should get mental health help. I want to be clear here that do not be surprised if you see overlap, just because how these young kids got exposed to the blast. And I'm talking about the artillery guys in the New York Times article. I'm talking to those who got it in combat. It's really tough when you see these young kids come rolling in, and yes, they've gotten a gunshot wound, they got a shrapnel wound, they've got a traumatic amputation and all that, but they're all been in one of the most horrific experiences they'll ever face in their lives. And just the idea of watching your friend die in front of you is just a very different experience altogether. So I know what we do on this line, and I know my fellow clinicians, but these are people who serve their country nobly, and they've been involved in some extraordinary experiences that have long-term consequences. We are privileged. We are privileged to have the skills and the dedication to try to help them. But understanding them, they're not like the kid that came in from across the street who's at his prep school playing soccer and got bonked on the head. That is not the same 18-year-olds who wore a uniform carrying a weapon downrange in the mountains of Afghanistan. Those are two completely different patients, and we have to be sensitive to them.
Yeah, absolutely. I hear what you're saying. And let me follow up on that a little bit. What struck me, maybe in the New York Times article, but also in clinic, is I appreciate the distinction between the PTS, PTSD, and the blast injuries. But is there not in clinic some overlap sometimes that can't be explained? And they touched on this a little bit in the New York Times article. One of the soldiers they interviewed said, look, I didn't see those horrific things up front. I was firing, long range. And so I didn't see on the daily the horrific things, but yet he was having visions of that. And that's what was keeping him up, and perhaps it was sort of all of the emotions that go along with being in that theater. But also we see this sometimes too in clinic where I do get the deployment history, and it wasn't right up front with the forward teams, but yet there's a significant amount of mental health. So I feel like I see that a lot. And so I do have a bit of trouble sorting it out sometimes in clinic. And maybe it's the upbringing, maybe it's remote experiences. Maybe it was a tough childhood that feeds into this and makes you more susceptible. I'm not sure. What are your thoughts on that?
Let me give you another patient cohort that's been studied. You can look this up. It's the UAV pilots, unmanned aerial vehicle pilots, the Predator drone pilots, right? They are not sitting in the cockpit of their plane dropping weapons. They are often in Reno, Nevada, at Creech Air Force Base, flying these drones halfway around the world. And the incidence of PTS is very high among them. So how could that be? They're not in combat. They're not even in an airplane. It's because they're remote. And it's because of many of the things that they are processing, that they are flying. They know that their system that they're flying will and cause death and destruction. Like these young artillery guys. They don't see where their rounds impact and how it impacts the enemy, but they know that their rounds are impacting and affecting other human beings. Most people are good people. They don't want to do bad things, Stacey. Even in the setting where they think it's absolutely essential to do bad things, they don't want to do bad things. It's really hard when you're put in that environment. So a lot of these young people that you're seeing in your clinic, in fact, could have a consequence of exactly that. But if you look at the UAV pilot study, it's actually very, very intriguing and provocative in the sense that, oh my gosh, they are suffering without a doubt from a PTS type of syndrome, and yet they haven't been in actual combat in the strictest sense, just like these artillery guys.
And I wonder if the exposure to the blasts somehow makes your brain more susceptible to that piece of things. Do we know?
Absolutely yes. Absolutely yes. I think about it. I mean, you're going to need all of your neurons to be able to process these sort of very complicated situations. And if you are brain addled because of the shock wave, of course you're going to have a harder time processing it. Nobody wants to have a concussed patient doing job wherein their decisions impact life limb of someone else. For example, you don't want somebody who just got a concussion to go fly a jet passenger airplane, right? So because you need all your neurons firing.
That's really helpful. Any final thoughts?
So before people start blaming other people, which is a little bit what I saw in that New York Times article, they were sort of blaming, why didn't somebody do this, somebody do that? And I think that's Monday quarterbacking. I think what we have to do is be open-minded, recognize that we're learning more and more about different types of disease states in the world that you and I are talking about right now, this whole notion of mild traumatic brain injury. I bring you back to the 2000. And this is a time when people didn't really take concussions seriously. They just did not. It wasn't until after 2000 that people started taking it seriously. And we could blame all these people for how did they not know? Because they didn't know. So instead of blaming, let's move forward. Let's do what the VA has done, which is create clinical practice guidelines. Let's do what the DOD is doing, is starting to go and start to measure these blast waves and such in theater. And let's do what we need to do as clinicians and look at our patients and say, okay, it is what it is. How can I manage you in the best possible way, using the best evidence possible, and in the most appropriate manner, and then, of course, in the most compassionate way? Because these patients, when they come in, they've had the invisible wounds of war. And you've heard this term before. They have the invisible wounds of war. It's much easier to take care of a patient and have compassion if they're missing a limb. But what about the patient who has had a brain injury? And we as neurologists know that the brain is the most important organ in the body and that it is very sensitive. But we have to start with the beginning, and that is with the one single patient sitting before us.
Well said. Thank you again. Geoff's currently a neurologist at Johns Hopkins, but prior to this long career serving in the U.S. military, retired as colonel, and also the founding director of the DARPA Biological Technologies Office. Thanks again, Geoff.
Thank you, Stacey.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.